All righty. Well, thank you for all of your patience and timeliness, and very grateful to have you all as we celebrate our wonderful colleague who has completed all of his scholarly work in the College of Graduate Nursing, Doctor of Nursing Practice program. My name is Dr. Donna Emanuel. I am the director of the DMP, and I could not be more proud of Christian Custodio and all of his wonderful contributions and meaningfulness to this particular scholarly project that he's going to be sharing with each and every one of you this morning. So with that, I will hand over the reins to Christian to begin his presentation, and we'll take Q&A at the very end. And so Christian, whenever you're ready, you may begin.
Thank you, Dr. Emanuel, and good morning, everyone. Good morning to all the Western U faculty and staff, esteemed Dr. Lopez and Dr. Emanuel. I'm so ecstatic to share with you today the culmination of all my hard work in the past 2 years, titled a pilot project integrating the use of a patient navigator to improve medication adherence amongst patients with type 2 diabetes at a primary care office. I want to begin my presentation by defining some key terms to better frame the concept being discussed. Type 2 diabetes, or simply diabetes, is a disease that results from the blood sugar being too high. Uncontrolled diabetes is a person with type 2 diabetes that has a daily average blood glucose level of 200 milligrams per deciliter, or a hemoglobin A1C of 7.0 and greater. Hemoglobin A1C, or simply A1C, is a blood test that measures the average blood sugar level over the past 3 months. Medication non-adherence is a person's behavior towards taking a medication that does not correspond with agreed recommendations from a healthcare provider. A patient navigator is a trained person that helps overcome modifiable barriers and achieve the care goals by addressing individual needs. So a brief overview, 37.3 Americans have diabetes, and another 96 million Americans are becoming diabetic. This translates to 40% of Americans either being pre or current diabetic. Diabetes is often insidious, meaning patients typically won't notice the disease consequences until late. If left untreated, diabetes can result in disabling conditions such as nephropathy, which could lead to dialysis, retinopathy, which could lead to blindness, and peripheral neuropathy, which could lead to foot amputation. Along with diet and exercise, oral medication is the first-line treatment for diabetes. In the primary care setting, medication non-adherence is often cited as the most common cause of treatment failure among patients with chronic conditions such as type 2 diabetes. It is approximated that 50% of patients with chronic conditions are considered medication non-adherent. An effective intervention to improve medication adherence is the utilization of a patient navigator. The implemented quality improvement project was carried out in a clinic here in Pomona, California. The practice sees a total of 1,168 patients with a diagnosis of type 2 diabetes, an alarming 63% of which are uncontrolled. This issue, unfortunately, extends beyond the confines of the medical office. Current available literature shows that patients with low socioeconomic status were more likely to become medication non-adherent. The analysis of the city of Pomona revealed a 21% income poverty rate, which is almost doubled compared to the national and California state percentages. To better hone the concept of medication non-adherence, type 2 diabetes, and patient navigation, I have developed a practice question in PICO format to guide my literature search. The evidence-based research question is, amongst patients with type 2 diabetes aged 18 to 75 years old with a hemoglobin A1C of 6.5 or greater, what is the effect of a patient navigator in improving medication adherence in a 60-day period? Using the PICO questions I have developed, I started looking at relevant literature and about non-adherence and patient navigators. Several search engines were utilized to research the topic. I appraised 22 articles using the Johns Hopkins model. Most considerable number of articles were level 1A and level 3A. There were three themes identified in the literature review: barriers to patient adherence, economic cost to non-adherence, and interventions provided to deter non-adherence. For the first theme, barriers to adherence, majority of the reviewed articles discussed medication non-adherence and its causes. Two authors found in their meta-analysis that although causes surrounding non-adherence vary, it can stem from three factors: patient, clinician, and healthcare system issues. Of the 16 articles that directly and indirectly discuss causes of non-adherence, 12 authors attributed patient factors as the main cause of non-adherence. One author found that many patients stop taking their medication in the first months following initiation, often without informing the provider. Patient motivation is found to be a crucial driving force in medication adherence, which is a problem since many chronic illnesses do not have visible or perceivable symptoms until late. Thus, the patient believes that there's no problem. And of course, how the medication made the patient feel played a huge factor. Multiple authors found that patients intentionally not taking their medication due to the perception of medication and concerns about potential side effects. Prescribers are equally responsible for patient non-adherence. In the current literature, patients whose provider communicated well had a 19% higher adherence. Patient attitudes and perceptions toward their providers also can be a factor in adherence. Medication adherence was higher from specialists, physician assistants, and advanced practice nurses compared to primary care physicians. Lastly, the complexity of medication also affected adherence. The more often the patient had to take the medication, the more likely they become non-adherent. Healthcare factors include cost of patients and access to healthcare. Several authors cited financial hardship and patient income level as an important barrier to medication adherence. Although this is the case, eliminating medication costs did not fully increase adherence. Surprisingly, eliminating costs completely only modestly improved adherence rates. Despite having subsidized and even free prescribed medication, non-adherence was still associated with socioeconomic disadvantaged patients. The second theme identified during the review is the economic burden medication non-adherence has. Aside from the individual health outcomes, medication non-adherence also carries a substantial economic burden. There were several figures reported which range from 100 billion up to 290 billion in avoidable healthcare costs. The last theme identified is the interventions to deter medication non-adherence. This included education. Although education is identified as the key, authors argued that intervention should not be used alone. Rather, it should be used in conjunction with other interventions. Thus, in conjunction to patient and clinician education, integrating a patient navigator in primary care was found to be an effective deterrence to medication non-adherence. As a reminder, a patient navigator is an unlicensed healthcare personnel trained to the specific role. Multiple authors found that patient navigators may be ineffective in re-engaging patients with diabetes. After reviewing the current research available, it has become evident that current standards of care of medication prescription and recall in 3 months to check hemoglobin A1C is not an effective management for type 2 diabetes. Thus, I have developed a purpose statement which aims to increase medication adherence in a local clinic by integrating a patient navigator for patients with type 2 diabetes. True to its purpose, I have designed and implemented the project aimed to evaluate the integration of a patient navigator into the primary care office to enhance medication adherence among diabetic patients. This project had two aims, where aim number 1, evaluate medication adherence, and aim number 2, evaluated medication side effects that deter adherence. A theoretical framework called the Newman System Model was used to provide structure to the quality improvement project. In this framework, the patient is viewed as the core with concentric circles which contracts and expand based on the patient's response to the environment. There were 3 levels of prevention in this framework, but we will focus on the first 2 preventions. Primary prevention is the intervention given before the stressor reaches the patient, and it aims to reduce the likelihood of stressors. Examples are health promotions and vaccination. Secondary prevention is a level of prevention that takes place once the stressors has penetrated the innate defenses and caused illness. It helps patients return to normal homeostasis or pre-illness state. Examples include taking prescribed medications. So how does this framework used to support the project? When the systems model is applied to the quality improvement project, using screening tools to catch medication non-adherence is a primary level of prevention. This intervention will identify potential medication non-adherent patients and prevent occurrence in the first place. The use of a patient navigator to encourage patients to take their prescribed medication is a secondary level of prevention. This encouragement of taking prescribed medication minimizes potential damage to patients and allowing resiliency to the disease. Now for the implementation of the project. As we previously mentioned, the project setting is a medical office in Pomona with multiple providers that treats an average of 170 patients with type 2 diabetes within a week. To be eligible for recruitment, patient must be between 18 and 75 years old, have a diagnosis of type 2 diabetes with an A1C greater of 6.5 within the past year. The patient also must have the clinic as their home base and of course has to have a working phone. The role of a patient navigator also had inclusion criteria. The medical assistant must be at least 18 years old, currently employed in the clinic, and must receive both an in-service training and a city certification. This practice improvement project spanned 3 months in length from March to May 2024. 30 patients were sampled for this pilot study. The sample size was filled within 3 days of program initiation. The project used a measurement tool called Adherence to Refill and Medication Scale for Diabetes, or simply ARMS-D. It is a validated and reliable tool that measures medication non-adherence among patients with diabetes. This tool not only strongly predicts A1C and glycemic control, but also predicts self-care behaviors leading to improved glycemic control. The tool has been tested against other validated tools used to measure medication non-adherence and showed comparative validity. Here we see the questions in the tool. The questionnaire is composed of 11 questions. All were answerable from a 4-point Likert scale, with none of the time equaling 1 point, and so forth. As you can see, the questionnaire asks questions surrounding patients' surrounding medication habits. The higher the garnered point, the higher the likelihood of non-adherence. The tool has 2 subscales. The blue highlighted numbers are questions regarding medication taking, and the yellow highlighted numbers are questionnaires regarding medication refill. The design of the project is simple. Providers and office staff members were asked to help identify patients, and then they were referred to me for recruitment. If the patient was agreeable to participate, consent forms were obtained. The participant is then assigned to one of the 3 navigators. Initial enrollment began on March 15, 2024, and patient navigation interaction ensued 2 weeks after enrollment date. Patient navigators asked 4 questions. Were you able to get your diabetic medication from the pharmacy? Are you taking any of your diabetic medication? Have you noticed any side effects with this medication? Are you having any general issues with your medication? After the 4th call, the patient navigator administered the ARMS-D tools over the phone. All the data collected were given to me for analysis. The first step of data analysis I have conducted is running a descriptive statistical analysis to summarize the baseline characteristics of the sample. As we can see in the table, the sample collected was very much reflective of the population for which we serve here in our area. Majority of the patients were older, Hispanic male or female with a type 2 diabetes. I can't believe all my hard work can be summarized in one slide, but here it is. For the project's first aim, which is evaluation of patient adherence, I performed a 2-tailed paired sample t-test to determine the relationship of the pre and post patient navigation intervention. The t-test scores was significant based on an alpha value of 0.5, 0.05 and a p-level of 0.001. All that means is that the patient navigation program was impactful. Remembering that with the ARMS-D tool, the lower the test scores, the less likely of medication non-adherence is. As we can see in the graph, there was a significant decrease in all three categories: medication refill subscale, medication taking subscale, and the ARMS total scores. Aim 2 of the project is to explore medication side effect that stops patients from taking their medication. A descriptive analysis were calculated to describe if patients experience any side effects. During the patient navigator interaction, it was found that 23% of patients reported feeling symptoms related to their diabetic medication use, which we will talk more in detail in the upcoming slides. As was demonstrated in the result, there was a significant decrease in the ARMS-D post-intervention test scores observed during the 60-day patient navigation program. This decrease in total ARMS-D score indicates an overall improvement in patient medication adherence. In the context of mitigating non-adherent behaviors among patients experiencing medication side effects, the Navigator program facilitated prompt reporting to the prescriber. A near quarter of the patients in the Patient Navigator program reported to have experienced side effects after medication initiation or dosage change. These patients met with their provider and they either received further education on medication use, dose adjustment, or change in their medication regimen altogether. This timely scheduling enabled provider-patient discussions about alternative medication options, reducing the likelihood of patient self-discontinuation of medication without professional guidance. There were some limitations identified during this quality improvement project. The project's design did not allow to directly measure A1C levels to assess the diabetic improvement, and instead relied heavily on the predictive capability of the ARMS-D. Staffing shortages led to the reluctance amongst medical assistants to take on additional roles and responsibilities as patient navigators, thereby limiting the sample size. Finally, the project did not address the multifaceted barriers identified in the literature review, such as patient motivation, patient-prescriber relationship, and healthcare system barriers. These limitations highlighted the need for further projects to develop more comprehensive interventions aimed at improving medication adherence. The demonstrated improvement of medication adherence with patient navigator use can be translated into improvements in diabetic management, resulting in patient-better outcomes. Sustainability of the patient navigation can vary across clinics due to the different staffing roles. I suggest having the medical records or referral departments take on the patient navigator role. Using the ARMS tool during the annual wellness exam can help identify patients to risk of medication non-adherence, but it has to be administered verbally for accuracy. Identifying this patient allows them to join in this or similar programs. For future projects and research, exploring the relationship between the duration of diagnosis of diabetes and patient engagement in greater depth can give researchers and clinician insights into patient receptiveness to education. Further investigation into patient satisfaction with patient navigators could also provide valuable insight into overall patient engagement. Finally, a longer study analyzing the effects of patient navigator improvement on hemoglobin A1C levels would address the identified limitations and provide a more robust data. To conclude, patient medication non-adherence is the leading cause of treatment failure in patients with chronic illnesses. Current practice standards of clinic recall in 3 months are not effective. The Quality Improvement Project demonstrated the effectiveness in deterring medication non-adherence by actively engaging and addressing patient concerns. The patient navigators help bridge the gap between patients and healthcare providers. This approach fosters a comprehensive and supportive care environment. The American Association of College of Nursing Core Competencies 1 through 8 served as a foundational guide for this scholarly work. However, domains 1, 2, 3, 4, 6, and 7 were the most impactful for this scholarly work. This concludes my presentation. If you'd like to view my abstract and references, please use the QR code presented in your screen. Before I take any questions about the project, my academic journey is paved with support and assistance from many individuals. I would like to thank the ReadyCare team, especially for my wonderful patient navigators, Dana, Alexis, and Alejandro, for your support and participation in the implemented project. For all the Western U faculty and staff members, especially for Dr. Imai for your leadership and mentorship, and of course, Dr. Trasher for your guidance. Lastly, and of course, my family, especially my wife, who have never doubted my success. Excuse me. And my mother and my sister who have been proudest of my achievements. Thank you. I will now be taking questions or comments.
Well, congratulations, Dr. Christian Custodio. Very proud of all the work that you have done. And my only question for you is, what might you anticipate as your next steps?
I would definitely like to publish the research findings that I have, but I would definitely like to do a little focusing on family right now. As many of you guys have known, my wife had delivered our baby in the middle of our program, and that was pretty difficult, balancing work, career, and of course this work that I've been doing. But that's definitely something I'm looking forward to do.
That's exceptional. I think you've got a really nice benchmark for best practice that other facilities and primary care centers can embrace and replicate a majority of your work as well. So kudos to you, and I embrace you in all of the work that you have put forth. I know it's been a trying time, but you have done wonderful work. We'll take questions from the audience. Dr. Mary Lopez, you have your hand raised.
Thank you. I just want to say congratulations, Dr. Custodio, and to your team leader, Dr. Amai. This project was so well put together. I was really impressed with every part of it. And it's very, very important work. And it's going to make a tremendous impact. And I love that you were able to bring your team leaders, participants here, the patient navigators, to be a part of this, because our reach out from academia into the community is essential. And that really shows their support as well. So congratulations, well done. Your document was very well written, and very, very proud of you.
Thank you very much, Dean Lopez.
Congratulations, Dr. Amai.